Good afternoon, everyone. I'm Dr. Angela Taveda-Dick, and I'm the Associate Director for the Military and Veteran Psychology Program. It's my pleasure to welcome you all to our Military and Veteran Continuing Education Series. This is a grant-funded series that provides knowledge of military-focused topics to those who are in connection with service members. Our series takes place virtually once a month on a Friday from noon to 1. Our training for next month will be on February 9th at noon, and will cover safer weapon storage with military and veterans. Before we get started, it's my pleasure to introduce one of our students, Tangira Spalding. She is a fourth-year student in our clinical psychology doctoral program. She earned her bachelor's degree in political science at the University of Hawaii in 2022, and currently serves as a 2LT in the Army Reserve through the Health Profession Scholarship Program. And she will be transitioning to active duty in a few months.
Thank you for the introduction. Hello, everyone. So today's presentation is titled Cognitive Processing Therapy for Providers of Military Personnel and Veterans, presented by Dr. Daniel Jacobs. Dr. Daniel Jacobs received his PsyD in clinical psychology from William James College, which was then known as MSPP. And he also earned a Bachelor of Arts from Brandeis University, a Master's of Education from the Harvard University Graduate School of Education, and an MBA from Salem State University. Dr. Jacobs has had a private practice for over 20 years and works with law enforcement, firefighters, and other first responders who are military connected. He is also an associate professor at William James College in Newton, Massachusetts, and teaches in the school psychology and organizational leadership psychology departments at William James College. He was formerly the director of partial hospital programs, adolescent and adult, at NSMC Salem Hospital in Salem, Massachusetts. He has presented over 200 professional trainings for professionals on topics related to mental health and substance abuse prevention and intervention issues. Dr. Jacobs has a strong background in cognitive behavioral therapy and uses this along with utilization of other psychological theories to help clients find successful ways to address their concerns from a strength-based perspective. So thank you, Dr. Daniel Jacobs, for being with us today. I will go ahead and let you get things started.
Terrific. Thank you so much. All right, so let me share screen. Okay. All right. So hi, everybody. I'm Dan Jacobs. As was just said very nicely, I've done a bunch of different stuff. I'm a clinical psychologist by training, but I worked in education. I worked in hospitals. I worked in schools. Got the business degree back when I was in hospitals because I was at a very nice community hospital, got taken over by a giant monolith called Partners Healthcare. And it ends up most clinicians don't speak numbers. So it helped me to fend that off and protect my patients. Because I have a subspecialty in addiction and because I've subspecialty working with police and firefighters, I have worked with a lot of more veterans than active military. I'm not a military myself, but I've done a lot of work with those folks. I have family members, an uncle, my daughter. So I have a lot of respect for the work folks do. What I'm also going to be trying to do today is the impossible in 1 hour to talk about this giant concept. It is less impossible than the last time Dr. D'Olimpia and I did this because Dr. D'Olimpia started a series where we are helping clinicians, psychologists and clinicians in Ukraine right now, helping their military folks with issues. So give a version of this. The reason that was more complicated is I was speaking in English, Victor was translating to Ukrainian, we were taking questions back and forth, and our idioms and things are very different. So I'm still going to try to do the impossible today. At the end, when some of you are thinking, I wish we had more detail, I'm going to show you how to get some different details. One of which is freely accessible through the Department of Defense website. It's in the references at the end. And the other is not, which is why I'm not sharing it, because it is from a published book by the authors from 2017. And I don't have, both sources you are certainly welcome to use. One you can get for free, one you have to pay for. I don't have permission to release it to a big group. That's the only reason. It's not that I forgot. I'm trying to respect their copyright and their issues. Okay. So as was said, I've worked in all those different settings. The reason I'm mentioning that again is because I have been trained to think very differently in different settings. Education world taught me one thing, business world taught me another thing, clinical psych taught me another thing, and my work with military, police, and fire teaches me a different way. Not everybody thinks the same way. Not everybody perceives things. So what's helped me is being able to jump mindset, if you will. And cognitive processing therapy along the way is one of my favorite things that I've encountered. I've been a big CBT guy for years anyway. I'm a big narrative therapy fan. I was originally trained psychodynamic because I was trained in Boston and everybody was. So I'm today going to be really what's useful, what's practical. And again, I want to thank Dr. D'Olimpia who got me involved in this wonderful military and veterans program here. I've seen some of those students both in the clinical department and the organizational leadership psychology department. And it's just a pleasure working with these folks. All right, so again, I'm trying to do an overview here of a cognitive processing therapy, and I'm particularly focusing and absolutely, by the way, while it was started to work with active duty and then veterans, now absolutely you can use this with civilians. I'm not going to spend a lot of time today talking about the use with civilians, but of course it's relevant for people with trauma, the civilian community. No one's going to be an expert after this 1 hour. If you're already a CBT person, some of the stuff I'm going to say will sound repeat. If you're not, it'll sound new. And I'm going to tell a narrative story. I'm going to talk a little bit about overview and then build in, and then I'll give some examples. I hope at the end of this, you're super interested in this and want to learn more about it. I think it's incredibly practical. I'll jump back and forth between the group and individual modalities. I'm a big group guy. I'm a big individual guy. I like groups for all sorts of reasons. Not everyone does. This can be useful in both, okay? And as I said a second ago, at the end in the references, I will point out two very specific, all the references are good, but two, one you can just download, boom, from DOD, it's great. And then the other one is a book, you can buy it, you can not buy it. I don't have any financial connection to it. I think it's a terrific book by the same authors of the DOD material. DOD material is from 2014, the book is from 2017. It's a little updated, so slightly different. I'll explain that when we get to it. Okay. All right, so obviously, I'm not going to sell you too much on this one. We know psychotherapy can be useful to help veterans and active service members deal with commonly experienced psychological issues. And again, I'm not talking about everything, but I'm telling the stories. I'm zeroing in. Of course, depression, anxiety, substance use and abuse concerns. I know we could say substance use disorder. I know we could say substance issues. They're in the DPH community. Substance abuse is being frowned upon right now. I disagree with it because there is a difference between use and abuse. And I also work with adolescents. There's never an acceptable usage of heroin or something like that in that crowd. So I'm not using the word willy-nilly. I know what I'm doing with it, but I get not everybody agrees with it. And I'm not saying substance use disorder because not everybody we're talking about today qualifies to ring that bell for SUD. Relationship issues, of course, is an issue. And then, of course, post-traumatic stress disorder or some form of traumatic response. We know that, and as much as I'm a fan of behaviorism and CBT, we know it's not the only game in town. I would never say that. That makes no sense. I've never understood why somebody says they're rigid and only have one philosophy. But CBT is incredibly useful with this group. Psychodynamic can be very useful, behavioral, and narrative therapy, as I said, is terrific. I've done that on different days. That's not what I'm doing today. But I try to jump from all of these things. They're very helpful to military personnel. And it's really important that we get the perceived relational connection between the therapist and the client, because that's as important, even more than the type of therapy. When you ask clients or patients, they don't really care what our modality is, what our philosophy is. They care, do they trust us? Do they feel connected with us? And many studies have shown us that how the patient views the relationship is much more important than how the therapist views the relationship in terms of are they going to stick around, in terms of are they going to do more work and be more engaged. So obviously psychologists have helped many in the military deal with the issues above, but it's hard to help the ones who won't come in to talk, right? What do we always say? If they're not in my office, if they're not in my group, can't help anybody we can't talk to, right? And I don't get into the whole thing about telehealth and pre-recorded and asynchronous. For my purposes, I'd much rather have somebody in front of me. The person we can't help is the one who doesn't show up. So many veterans and active service members have a number of reasons why they don't want to participate. I just spent the last 3 weeks, I'm still in the middle of a big testing project of people who want to be state police members, and overwhelmingly, a lot of them are military. I'm often the first psych person they've ever talked to, unless they had to see somebody when they were being discharged, and that was brief, or it was in a critical incident. a lot of them don't like us. We scare them, right? They can handle all sorts of situations, but we want to talk about feelings and we want to talk about issues and family dynamics. And that's very weird for a lot of folks, right? So what do they often say? Well, everybody knows talking about feelings doesn't make anything better. Needing to talk to, these are all from real people, right? Needing to talk to a psychologist is a sign of weakness. That's a huge belief that I, of course, think is a myth, but they believe it, they believe it. Therapists think they know what I'm going through, but they don't. So it's a waste of my time. I'm barely holding on. What if it makes things worse? Which is a great one. So somebody really being overwhelmed by their emotional state and makes sense. So defensiveness always makes sense. It just becomes ineffective or maladaptive. So we have to figure out what to do with it. By the way, the third one, therapists think they know what I'm going through. The program here at WJC is wonderful because, as I was just introduced by one, military members learning to be psychologists is great and they connect. There aren't enough. So those of us who are not military have to at least learn as much as we can about the language, the culture, and make it very clear, I am not military, but I am military friendly, I'm military supportive. And even simply knowing terms like MOS or DD-214 or what was going on or what's in your jacket, it just helps them to see that we bothered enough to care. When those of you who work with multiple services, you do have to be careful that Navy terms are not Air Force terms, are not Army terms, et cetera, et cetera. And then, of course, realize that whatever branch they're from, they believe that is the best branch, which is fine. And just don't get into that one because you'll lose. All right. So also when a soldier, and I'm using soldier to mean anyone in the military, feels they're barely holding on in terms of emotional stability, the thought of having to talk about loss or pain or other concerns is terrifying. And that supports fear of change, of course. They may have been using other coping strategies, and this is how I came to it. The majority of the folks I work with, they've been self-medicating with alcohol, other drugs too, but alcohol for the most part. Isolation, avoidance, anger, and fighting to cover up pain. And they have now developed additional problems and they feel overwhelmed, they don't know how to get help. So that's why CPT was designed, specifically originally to help military connected patients get past the barriers in treatment. And it's, as I said earlier, it's very successful with non-military folks also, but it was built for the military originally. Okay, so what are the roots? We know that cognitive behavioral therapy, CBT, explores thought, feeling, action, or event, belief, emotional response, action choices. We know CBT focuses on how thoughts can impact behavior. So I'm driving down the highway, somebody cuts me off, I'm scared. Oh, so the guy cutting me off made me scared. No. My interpretation or beliefs of the guy cutting me off. I either thought, oh my God, that's so dangerous, I could die. So it's event, belief, emotional response, action. And that could lead me to slam on the brakes. That could lead me to the other way. If I interpreted, he's out to get me, that's disrespectful, I'll show him. So in one case, the same event, somebody cuts me off at high speed. One says I'm scared, I slow down. The other says I'm angry. And I speed up, and this is Massachusetts, so I get in front of him, and then I slam on my brakes. And this happens quite a bit, right? So it's not the events that make our feelings, it's our interpretation of the events. But it's super quick, and most people are not aware of it, and they'll say to you, what happened when you punched that person in the bar? Or what happened when you hit that person in the barracks? And they'll say, I don't know, I just was angry. And then we say, what happened before? What happened immediately before, right? So precipitating events. So that's some basic CBT stuff. We know that events, the stimuli impact they're filtered through the thoughts and beliefs. That affects the feelings and then our choices and actions. And a lot of the folks we're meeting at this stage, their choices and actions were ineffective or maladaptive. We try not to say good, bad, but it's, what were you trying to do? I was trying to protect myself. Well, did that work when the military police then arrested you? Well, no, then I was in much more trouble. Did it work when you then got busted down from an E5 to an E4? Well, no, so their intent was to protect self and actually didn't work. So what I found when we start breaking down basic CBT with my military patients or clients, they get it. They go, well, no, I was going to do this. And then we say, did it serve the purpose? Did it achieve what you were trying to do? Because they're goal-oriented, they're trained, they understand. And then they'll say, but I can't do anything about it. Okay, so that's not logic anymore. Now we're dealing with emotion or frustration. So what about CPT? So we know that patients, clients learning CBT, see they can learn to modify their thoughts because that's the first thing we sell them, right? Just because that is the way you have interpreted things doesn't mean you always have to interpret things that way, where we can change it. So we can choose to act. So we can learn how to challenge cognitive distortions and false assumptions that feed into self-defeating behavioral patterns. So again, I'm on the highway, the guy cut me off, everybody's out to get me. I'm always being under threat. I should protect myself. And if I am military and I've just come back from a war zone and I've learned that someone cutting off in front of me or a object in the road could be an IED, actually, I may have learned an adaptive skill in one setting, which is protect myself, swerve the car, speed up, slam on the brakes to save my life and those are the people with me. But now I'm in a civilian setting. It's very maladaptive or problematically dangerous, right? So the cognitive distortion is everyone's out to get me, everything is bad, everything is good, depending on the different version of it. So we help them realize, well, those are things that can be, you learn them, you can relearn them, you can replace them, right? So we know that cognitive behavioral therapy, and by the way, I'm saying cognitive behavioral therapy because it's one thing. We know, of course, there's 14, there's 15, could even be 20 versions of it by now, but there's REBT, DBT, ACT, MI, MBSR, prolonged exposure, PE. All of those are quite different, some of them, but they're all under the umbrella of cognitive behavioral therapy. But there's always the focus on the thoughts, the emotions, the actions, and there's always the focus on learning new ways to manage concerns such as anxiety, depression, anger, and issues linked to post-traumatic stress disorder. So before I even say any more on CBT, my military folks love the concept of CBT because they're used to learning a new skill set that will help protect them. And I frame CBT in that way, and they get it. CPT is, you could argue, even a little bit better in that because it was tailored. It's one type of CBT, and it's considered an evidence-based psychotherapy. It's originally designed specifically used for the military, and it's been shown to be quite successful. So Resnick, Monson, and Chard in the early 90s, probably later 90s, early 2000s, they had all been doing work on earlier trauma work with sexual assault survivors originally specifically. And they started modifying what they knew about that into what becomes CPT to help military personnel and veterans address symptoms of PTSD in different domains and areas, including intrusions, avoidance, negative alterations, cognitions of mood, and hyperarousal. So now in 2024, of course, we look at it and go, yeah, those are symptoms of PTSD. But in the mid-90s, the definition of PTSD hasn't even been around that long, right? Because it's the VA folks in Jamaica Plain in Boston and their colleagues, early to mid-80s when PTSD becomes a term, right? Replacing earlier terms. So this is only about 10 years later. And they're really doing some very, very cutting edge work at the time and now building on it. So intrusions, avoidance, negative alterations, cognition, mood, hyperarousal. And they were really incorporating a biological piece into the puzzle. And there are connections between biological underpinnings of PTSD and why CPT works. So some of it's linked to newer research on the amygdala, which when activated triggers, and most of us in a private office don't have access to all this machinery technology, of course, but we can benefit from it. So, when the amygdala is triggered or activated, it triggers strong emotions. It sends neurotransmitters throughout the brain to activate emergency response. Danger, must protect myself. IED, must protect myself. Person coming in with a gun, must protect myself. Makes sense. Bear coming at me, must run, right? These days, there are some people, in fact, literally the Park Service had to just release this the other day because some people see bear and they say, oh, Instagram photo, and then they get attacked. So the National Park Service, I think 2 days ago, just said, please don't pose and take pictures with bears. So sorry. Also, among those with PTSD, there's diminished responsivity and smaller size of the prefrontal cortex. By the way, I cannot tell you how to do therapy with everybody who lives their life on Instagram, and that's the most important thing. I'd much rather work with my military folks. In a normal fight-flight response, activity in the prefrontal cortex, which is where we think the seat of decision-making control over the amygdala is, it decreases. And other immune functions and normal physical processes, digesting food, right? So danger, I'm not hungry anymore. Danger, I don't have to run to the bathroom anymore. Danger, I must just run, I must fight or flight. And then we know a couple of years later, we added freeze, right? So it used to be fight or flight response, now it's fight, flight, or freeze response, depending on the past trauma, depending on other threats. The natural emotions accompanying fight or flight are generally fear and anger, right? Which not everybody's okay with. I just was in a group yesterday and someone was talking about how they were basically saying anger's bad. Anger's a bad emotion. And we had a whole conversation about, well, no, there's no such thing as a bad emotion. It's what do you do with it? How does it impact you? And of course, that's a thing we know, but it's important to bring about in therapy. This was in a group therapy session, so it was very useful to have that discussion. During the life-threatening emergency, it's of course more important to activate brainstem neurotransmitters to aid in fight-flight response. We have to go into danger mode. So in a well-modulated emergency response, and we'll see the figure in a second, the prefrontal cortex is activated just enough to notice when the danger's over, and then it sends messages out again to stop the fight-flight response. So there's a reciprocal relationship between prefrontal cortex and amygdala, right? So by the way, I do a lot of work with adolescents, and they do a lot of risky things and dangerous things and problematic things. And when you say to them, why do you do that? They say, I don't know. And people think, oh, you're being defensive or not. Well, no, they're 16, and we know the prefrontal lobe and the frontal cortex, it's probably not fully developed. We used to think 20, now we think 24, 25. So when they say, I don't know, or I haven't thought about it, they are limited in executive functioning prefrontal. And when we see some of our military, depending on the newer recruits, you could be talking to an 18-year-old soldier, a 19-year-old soldier, a 20-year-old soldier, who may be wonderful and mature and terrific for their age. Their prefrontal lobe is still not fully developed. So when we're dealing with people who are doing things that they thought were to protect themselves, but it seems illogical or dangerous, biologically that makes sense, right? So we look at this. This is the thread is there, the amygdala is there, and then the brain says, okay, whoa, no, we're gonna turn off. We're gonna turn it on when there's danger, and we'll turn it off when there's danger. But similar studies, people with PTSD, the amygdala shows heightened responsivity, with prefrontal cortex shows decreased activity. So because in this person with the PTSD exposure, not just traumatic exposure, but they've actually to the point where they have developed PTSD, their amygdala is too highly activated. Their brain said, danger, let's really go into danger mode. They have a much harder time, or it takes much longer to recognize perceived danger as entered and to calm down, right? So that they're not slowing down, which is why they are in that heightened state, and then we could say overreactive or reactive state for too long. So you can think of it in a temporal way, or you can think of it in an amount way, right? And then in imaging studies, when they looked at the actual brains in these people, and they showed them pictures of emotional faces or dangerous objects, and they said, pick pictures that match the original pictures, label the emotions or objects in the first case, they couldn't see the change. But when they asked to label the objects or describe whether each picture was a natural or artificially created danger, the instruction to use words resulted in activation of the prefrontal cortex, including Broca's area, which if people have worked with folks with TBI, traumatic brain injury, that comes up quite a bit, amygdala quieted. So then Resick talks about, she found and her team found, if merely labeling objects or pictures is sufficient to activate the prefrontal cortex and quiet the amygdala. So they were dealing with folks who amygdala went into heightened mode and couldn't slow down because of the trauma. And then they said, oh, but when we show them these things and they have to use their words about it, if they talk about and answer questions about the trauma, it's actually slowing things down a bit, right? And there was originally a thought, well, if we have people talk about their trauma, they'll be heightened and it'll make it worse. And actually, no, they're already thinking about the trauma. So talking about it, in fact, was a good way with the right containment. Back in the 90s, working in psych hospitals in Boston, not just with military, but people dealing with PTSD, when I first started in training, the concept was, don't talk about people about intense trauma in the outpatient community, wait until they're in a safe environment like the inpatient community, which is more secure, and you have 4 to 6 to 8 weeks to work with them. And anybody who's been around lately in psych hospitals, that's absurd now, because now people would say, oh, psych hospitalization for most folks is going to be 4 to 5 days because of insurance and money and whatnot. So don't talk about intense trauma at the inpatient level. No, do that in the outpatient community. It's a complete flip. And it's not really a philosophical flip. It was a reactive flip to resources, right? But the concept was still important. They do eventually have to talk about it. They do eventually have to learn coping skills with it. They do eventually have to feel supported by it. So Resick and her team found that the cognitive therapy could be a more direct route to change them. Clients just imagine traumatic events repeatedly, right? So this was adding in some more cognition. So they were really trying to layer in what they knew about trauma, what they knew about the biology, what they knew about CBT. And so then she said, it also reminded me, this is Resick talking, reminded me that daycare teachers know us intuitively when dealing with small children upset, use your words, right? Now, she's absolutely not comparing adult military survivors of trauma with children, but what she's saying is people who are completely overwhelmed and or have limited words can calm themselves by using the words they do have. By the way, what do we do with adults, forensic work, adolescents, anybody with real anger, rage issues? We don't tell them no. We don't say it's bad. We teach them as many coping skills as possible. Anybody who's ever done an anger management workshop, one of the key things we do is we teach them the difference between passive, aggressive, and assertive, right? We ultimately want to teach them assertive, and then we teach them coping skills, and we teach them verbal skills, and we teach them communication skills. So show me somebody with limited communication skills. I'll show somebody who punches people more. Show me somebody with more alternative ways to address their anger and rage. I'll show you fewer punches to the face of other people, right? It's not about right, wrong. It's what are your skill set. And again, military folks who started with this little of training, but then kept adding different specialties, they understand they're adding skill sets when you explain it this way. So the person doesn't know about the reciprocal relationship between frontal cortex and amygdala. But they do know that our people talk about upsetting them, they can calm down. What is upsetting them? I already said about this prefrontal cortex not developed early, right? So if you have limited coping skills and you are traumatized, you are in worse shape than if you have more coping skills. That's not rocket science, right? We can be clear. So it ends up CPT could really, they believe, and I absolutely would agree with it, can assist such clients, people with fewer resources. It helps them develop affect regulation. It increases cognitive flexibility. It can change a lot of assumptions and beliefs that were developed at pretty cognitive immaturity. So in fact, somebody pre-military, they come from a rough background, maybe they've been exposed to childhood trauma, adolescent trauma, neglect, abuse, and they learned nobody's looking out for you. You can only look out for yourself. Well, that person in basic training even is going to have trouble because they're told to trust everybody next to them in basic training. Not everybody can make it through basic training for that reason, but those who do and eventually connect, they might still have that traumatic background. They may still have that aggression. They may still have that tendency to go on the offense, but they will now include the soldiers next to them who, if they do feel accepted by them, they'll do anything at all to protect the person next to them, which is why I work with a lot of folks who I'm asking them about their history, and I want to know why they got bumped down from an E4 to an E3 to an E2. And it's a bar fight. It's a drunk driving incident. They were at a concert, they often say this, well, I didn't start it. Somebody was attacking my buddy. I had to step in. Well, what else could you have done? What are you talking about? I had to protect him. So they go back to an older skill set of threat, danger, use violence, but they're not doing it for themselves in that case. So you could argue this is great. They're protecting somebody else, except they then got arrested. And because I'm screening police and fire candidates, they may not get the job now years later, but that's a later consequence, which when they're 18, 19, 20, they can't think of that, right? Now, the good news is anybody who lasts in the military and sticks around and has the right support and training, these incidents become fewer and far between. They may still not have addressed the history of trauma. And now if they're exposed to new trauma, the old stuff can bubble up, right? So that ignoring and shoving down, whether through becoming emotionally cold or distant, whether because of drinking a lot, because of whatever, it's going to bubble up eventually, right? We know that. So one of the key goals of CPT is to teach clients greater flexibility in thinking, just like CBT. We want to teach them how to think critically about what they've been saying to themselves, traumatic events. We want to say, why did this happen? Well, this would be similar with survivor guilt, right? I didn't deserve to live. He was better than me. She was better than me. It's my fault. Well, why? Well, I don't have worth. I don't have value. My mom told me I was a piece of crap. My dad told me I was a piece of crap. I got beat up. It was because I deserved it. So why didn't he or she next to me survive when I'm the one who should have died, right? That you understand where it comes from, but that is a person who's not going to be forward thinking because they're self-blaming and they're in a negative state, right? So CPT is a cognitive behavioral treatment. It's designed to teach the patients to reconceptualize trauma. So the one thing we definitely can't do, and this would be with any trauma work and resiliency work, we can't ever make the trauma not happen. We can't ever make history not happen. I just had this conversation with a patient yesterday. And she said, well, when will the trauma go away? When will the abuse? I said, well, that'll never go away. But when we first met, and because I've seen her a long enough time, I could say, well, when I met you, memories of the trauma were taking up about 90% of the real estate in your brain. How much do you think it's taking up now? And she said, oh, and we've seen each other a long. She said about 20%. So she'd like it to be 0%, but the answer may be she will always remember the trauma, but she may have many, many more memories and many more coping skills and many more positives in her life. And eventually, so the goal is not to make the trauma not happen. It's already happened. And for psychologists in the outpatient community, certainly they've experienced already, but it is for them to not be governed by it, but not be ruled by it. So again, people have been around long enough doing this work, it used to be trauma victim, then it was trauma survivor, and then resiliency theory says, well, no, we just want them to be Bob or Janet. They're not even defined by their trauma. They're them with this experience, right? The original version of CPT, which I'm a big fan of, but I get why changes were made, had a written exposure component. Later variations don't always have the written part of treatment. So the original version was soldier walks in, sits down with the psychologist, and she says to him, okay, we're going to meet 8 sessions. this is going to be to address your trauma directly. We're going to be talking about it at the end of today. I'm going to give you homework, which we would do in cognitive behavioral therapy also, but in CPT, the homework was specific on session 1. And I'm going to have you go home and I'm going to have you write in handwriting. I want you to write out the most prevalent traumatic event that's waking you up at night with your nightmares. And it was most prevalent because the person could have been exposed to 7 different events, but there's always one that rises to the top. Most powerful, most impactful, most overwhelming. And you'd think, well, why are you starting with that one? And the argument was, well, we want to tackle that right away because that's the one that's most pressing. Why were they having them write it? And by the way, write it, not type it, and not report it to somebody else. And I know people with writing concerns and dyslexia and different things. And the goal wasn't to be right perfectly. It was that it ends up there was a kinesthetic connection. For any people who've done a lot of that work, they were writing it out, and it's like I when I teach classes, I give all my students my PowerPoint notes well in advance. And I'm in class the other day, and we're on slides, which they have, and they still have a notebook in front of them. They're handwriting notes. And I said, "What are you doing?" And she said to me, "I remember it better this way." Perfect, right? There's the kinesthetic connection. The newer version doesn't require this, but the reason it was done originally was so the veteran or active duty personnel would go home, they would come back, and one of the very first things you would do in session 2 is you would say, "Now read me out loud the story," and they would say about, "I was in this battle zone, the person next to me was shot by this mortar, this is what happened to me, these are the nightmares I'm having." And whatever it is they wrote, they would say it aloud, right? And the original thought was, oh, this is going to scare them. They're already having the memories anyway. They're already having the thoughts anyway. Now they're sharing it. It also ends up by doing this and giving a very specific assignment and a goal. Well, anybody had been learned to take apart their rifle 10,000 times in basic training and everything, where take it apart, put it back together, take it apart, put it back together. Why are you doing that? So at a certain point, that my muscle memory started thinking, you're so good at it. So CPT was designed for military folks who really understood how to learn a new skill and repeat until they get good at it. So they need to see a payoff. They need to see that it works. A lot of outpatient folks who don't come from this world or don't come from a behavioral world, and they're coming from a much more, and again, I use supportive therapy too, but if you were in a non-directive mode, you would never tell the patient, "I need you to do this, and I need you to do this." And actually, they do quite well with it, right? And then you get to say, and did it help you, and did it not? And you talk about refinements, right? So a traditional format of CPT, so again, I like that handwriting one quite a bit. I get why it got shifted. There's newer models. There's all sorts of variations now, but that was the original. The traditional format of a CPT could be 12 weekly sessions, could be 8, could be 10. Whatever it is, though, you would tell the person right up front, right? And this is not because managed care steps in, and this is not because the legislature says you must tell people how many sessions, et cetera, et cetera. So by the way, this does not fit into like a really old school traditional psychoanalytic model, right? Which is there is no end date. You're doing the work and eventually you get there. But you would never say to somebody on session 1, here's what's going to happen. Well, no, this was, they say, "How long am I going to see you, doc?" And you say 10 sessions and here's what we're going to do. And you give them everything up front. And some people would say, "You're going to give it all away up front?" Yes. You're going to tell them everything in the structure because they're still going to do the therapeutic work, but now they are less anxious because we've told them what we're going to do. So with other types of CBT, as I said, there's already homework assignments, or we could call them practice assignments. And the patient has to be willing to engage in these assignments. You find out very quickly by session 1 or session 2, are they doing the work or not? I've had better success with my military folks than a lot of my civilian folks in terms of this. You have success with anybody if you make the case for them why it's going to help them. And they say, "This will upset me." And I'll say something like, "You're already upset. You're already having the nightmares. You're already drinking the alcohol, the drugs, whatnot. Why not try something else? If it doesn't work, it doesn't work. But how does it hurt you to try?" Right? And usually they can buy that argument. This assumes also they've shown up, right? So we're having this conversation. Some clinicians, by the way, find it hard to schedule. They initiate and deliver the service. Could be the workload, could be the availability, could be all sorts of things, right? But actually it works. And I liked that CBT is very direct up front. They say how much time you need with it. They say it's not a quick fix because complex issues can't be fixed quickly. So anybody saying, "Oh, we can do this in 2 sessions," how's that going to work, right? We're not really looking for a fix. We're looking for to adapt, to modify, to add new skill set, to deal with some very long-term impairments, right? Issues. So despite the time requirement, a lot of participants responded very positively to CPT as the clear structure and timeline of CPT, and I already said this out of order, were often described as aligning very well with the learning style of patients who served in the military. Veterans could relate to and feel comfortable with the structured and predictable nature of the manualized therapy, right? There is, and again, I'll point to it at the very end of this talk. There's a manual, and you can give it to them, and you can say, chapter 1, chapter 2, chapter 3. Well, guess what people in the military are used to? They're used to being given manuals. They're used to being trained. They're used to going, there's a start, there's a middle, there's an end. That is way less scary than, how long am I going to see you for? I don't know. We'll see. We'll take it as easy. They don't like that. This does quite well. It's structured and it's predictable, right? One provider said, this is a provider at the VA. I think patients are very appreciative of the fact that CPT is structured. They know what to expect. It's 12 sessions. In this case, it was 12 sessions. It's not like with a lot of other types of therapies where there's no end in sight. Sometimes that can be really daunting and scary. So somebody who's already anxious and already defensive and already isolating or rejecting help does not need to hear, I don't know, we'll see what happens. We'll play it by ear. No, this is very, very clear. By the way, it's not that at end of session 12, if the person still is in crisis, you say, see you later. No, then you would, of course, do additional sessions. But the actual plan is structured. Again, this is 12. It can be modified, but whatever you're going to do with them, you would tell them up front. Also, in the pre-treatment stage, there's a thing called the index trauma, and it's the traumatic event for which the client's experiencing the most PTSD symptoms. This is what I said, the one that rises to the top. They call it index trauma. Most individuals presenting for PTSD treatment have multiple traumas, right? Just like when we talk about people with this, in my substance use work, substance abuse work, I say to my students, well, I'm pretending like the person only has depression or only has anxiety. No, of course, there's multiple issues across the line. And when you talk to people with a significant substance use disorder, well, there probably is depression, anxiety, and or trauma, and or all three. And you have to address it. But something is still pressing. Something is still at the top of the list. And CPT, they say steer into the index trauma first, work on it first, because therapeutic gains on that trauma are likely to lead to faster improvements in PTSD symptoms, and then they generalize to the other traumas. So with the question of, one argument would be, hit the lower hanging fruit, the easier stuff, if you will, rather than the harder stuff. This argument says, no, tackle the hardest stuff, because once they make a small gain, they'll say, oh, this can help. And then they're way more open to making progress in other areas. And there's a lot of traumas that are thematically similar. So the interpersonal trauma in adulthood and childhood, as I mentioned earlier. In determining the index trauma, the clinician has to pay attention to these clues. What's the specific content of the intrusions, the intrusive thoughts? What's the negative cognitions about the trauma? What are their thoughts? I deserve it. I failed everybody. Whatever it would be, right? And the people, places, and events that are avoided, right? So we know, yes, it is good to avoid that bear who's right in front of you. Do you now not go to parks at all? Do you now not go to that town at all? How overgeneralizing are you making your defensive strategies, which very quickly become maladaptive, right? And those are all the symptoms of PTSD that differentiate it from anxiety and depressive disorder. So it's not that somebody with anxiety or depression might also not do these things, but we're looking for what specifically is PTSD related. So then what do? Well, so after the pre-treatment assessment phase, which could be a number of sessions, there's some it's quicker, some it's slower, it just depends, you would assess for PTSD, just like you would with anybody, whether it was CPT or not. You would then assess for comorbid conditions, like I just referenced. It's very likely there may be depression, substance use disorders, psychotic and bipolar disorders, risk for harm to self and others, personality disorder traits, sleep disruptions, medications, family involvement, if appropriate. If there's ongoing substance use, abuse, neglect, stress, trauma with that family connection, maybe there shouldn't be, right? But so it really depends. And hopefully the person sitting in front of us doesn't have all these things. Some people do. It would be layered, and we want to tease out what needs to be tackled first, right? Again, in substance use work, whether it was hospital or outpatient, well, somebody with a significant alcohol issue or heroin issue, if they were also suicidal, well, of course, we had to address the suicidality first, right? If they were enraged and planning to kill somebody else or harm somebody else, we had to deal with that first. So it's always about assessing greatest risk and whatnot. The CPT also talks about stuck points, right? Because a lot of clinicians have said they like that CPT takes into account the person's developmental history and the intersections of the traumatic experiences, they overlap. And they think the most important concept, or case conceptualizing concept for clinicians to think about is the assimilated and over-accommodated beliefs, because this gets you to stuck points. Stuck points are where in therapy, or actually initially just in the person's functioning life, but then for our purposes, therapy, where they're just not getting beyond them, right? So in CPT, stuck points are negative trauma-related appraisals that impede recovery, These are the problematic ways the client looks backwards about the index event. So they're talking about the trauma and they're telling you what happened, and why they deserved it. Well, if they're so stuck in the past, literally stuck, it's very hard to say, well, why don't you now communicate with your wife or husband? Why don't you now talk to your CO? Why don't you now? Because that's forward looking or viewing, right? So they're stuck in the past for good reason because they haven't worked through it. So we have to identify that, and then we make it explicit and we talk about it with them. Stuck points are the thoughts generally involved, hindsight bias, efforts to undo the event. There's a lot of what if, or I should have, I would have, I could have. And in CBT, we know would have, should have, could have is again a stuck point. Well, it's not about logic, but it's a cognitive distortion to agree. You know, Albert Ellis used to talk all the time about people shooting on themselves and what could he do and whatnot. Say what you want about Ellis, who was a very colorful character if anybody ever got to see him in person, but he was very direct about it. It's either helping, it's not helping, it's working, it's not working. What can we do? Let's tackle it, right? Tackling the stuck points could also include the attempt to wonder why the event happened to them. This is the stuck point. They want to go back to a just world belief, right? The world is just and fair, and something bad happened to me, therefore I deserved it, therefore I wasn't good, right? Which of course is not logically true, but it doesn't matter, it's how they feel it, right? So this is when we have a conversation with them about logic's over here and emotions over here, and they don't live on the same planet, and then we have to address it, right? And it doesn't matter what we think, it matters what they think and what they believe, right? To a sense, the world's predictable and controllable, and we talk about it's not always, and we can change. You know, I had somebody say to me recently, you know, life's not fair, meaning everything's going to go wrong and whatnot. And we had a conversation about life's not fair, but life's also not fair. Life just is. And then he looked at me and went, oh, okay, now you're going to get all Zen on me, doc? And he laughed, but he was listening. Because in fact, one perspective is the world or life doesn't care about you at all. It just is. So the question is, how do you interpret? And that's a very CBT interpretation, right? And I guess it is kind of a Zen interpretation. But and by the way, I don't mind if this rough and tough guy who's making fun of me is making fun of me because he's engaged. And the next week he started talking about it, and so it was fine. It was making fun in a playful way, if that makes sense. And he was listening, so I'll take it. I don't care. The clinician learns about the patient's point of views by hearing how they view the stuck points. How do they define themselves? How do they blame themselves? What's their rational or irrational about their beliefs? Are there prevalent cognitive distortion getting in the way of their functioning? Again, anybody with CBT experience, you'll know this is very common stuff. So when you introduce the CPT to the client, you say, hey, this is a standard course of CPT. It's 12 sessions. By the way, not everybody's going to have the exact same treatment. Some people use less than 12, some more, but 12 is what we're going to shoot for. I've had military folks come in and they say, I can beat that. And I say, what do you mean? He said, I'm better. I'm going to be your best patient. Somebody who's from a very competitive branch of the service, their personality are competitive. They want to be the best therapy client better. So you have to say to them, well, okay, let's do what we can. And by the way, I don't say, oh, don't do that. That's not how therapy works. I says, we'll see what happens. But by the way, maybe 12 is just exactly what you should hit. Oh, I shouldn't be faster? No, you should be just right. So I don't mind that because then they're already engaged. They want to engage, as opposed to being defensive and not showing up, right? And then I'll say very quickly, but you got to come to session 2, right? What do we say in any clinical interviewing class or therapy class? What's the goal of session 1? Get them to come back to session 2. What are we really saying? Relational dynamic, engagement, and CPT is no different. Clients participate in every session and complete the practice assignments the best they can. Of course, they improve the likelihood of positive engagements in the process. I'll tell them that up front. We tell them all of this. None of this is a secret. We tell them up front. Might be in writing also. We might give them the manual. Repeat. Nothing's a secret, right? Set up a therapeutic contract. We make it clear what the therapist and the client's expectations are. And this is later if they want to avoid or change topics, if they're really defensive, they're avoidant, whatnot. So similar to other forms of CBT, CPT has his use of Socratic dialogue, clarifying questions, challenging assumptions, evaluating objective evidence, challenging underlying or core beliefs. And here's an important point from the CPT folks. It's not just the clients who have stuck points. Therapists can have stuck points, right? Therapists can absolutely encounter them in treating those with PTSD. Therapists can have stuck points about themselves as therapists. The approaches they've been taught and have adhered to, their whole fear about trying a new approach, right? Here are examples. This is what the therapist would say, not what the patient would say. My client's not ready for trauma-focused therapy. My client's too fragile for trauma-focused therapy. If I use a manual, because there's a CPT manual, it will stifle my creativity, interfere with my rapport. Now, by the way, I'm not a giant manual guy and most of the time because I'd rather develop things myself. I've done 1 million groups in hospitals and groups and outpatient. But But if it's a good manual, it's useful, I will absolutely use it. I'll use anything that works, and I think this stuff works, right? So this is another thing a therapist says. CPT won't work with comorbidities, depression, substance abuse, personality disorders. Clients will not do this amount of homework. If I have the manual out, I will look incompetent. If I have the manual in front, they'll think I don't know what I'm doing, right? None of this has to do with the patient. This is all the therapist's issue, right? Their own stuck points. If we don't do the written account exposure, the client can't get better. I'll admit, I thought that when they started shifting it, I went, oh, but I like the written account, but I understand it, right? So these are not necessarily incorrect beliefs or thoughts, but they're not helpful to the person, and they are not the client's issue or the patient's issue. They're our issue. So we have to make it explicit so we can address it, because they're all basically forms of resistance to trying a new thing to help somebody, which is fine. And if in the end you read the manual and you don't like CPT, don't use CPT. But if you're going to use it, it does work. Sorry, it has a very high likelihood of working with a lot of people with these issues. Okay. So as I mentioned already, with other types of CPT, there's a lot of handouts, different sessions of CPT with a client. They address psychoeducation about cognitions, feelings, and actions. So what I did in 3 seconds, there's more information about it. They focus on stuck points. They explain that literally, explicitly. Self-defeating processes, cognitive and behavioral. I've alluded to some of these already or mentioned. They address habits, what the client's used to thinking versus facts and challenging misconceptions. So just like in normal CBT, we might say, okay, you think X, Y, and Z. You don't say, oh, that's not right. Or you say, okay, what's the evidence for it? And what's the evidence against it? And if they can only give one side, you say, well, you're loading the deck. You're rigging the deck. And they say, what do you mean? Well, you're only looking at the negative side of things. How's that fair? And then I can reference back to their military training and say, well, in basic training, if you were being asked to make your bunk a certain way or do a certain exercise, how did you know if you were right or not? Well, if I did it wrong, they yelled at me. I had to then do this or this. I said, but how'd you know you did it right? Well, actually, they would tell us sometimes that we did it right. I said, okay, is that fair? Actually, yeah, it was super fair. People who come from chaotic, neglectful homes, especially with trauma histories, and they go into the military, they love that, actually. So people in basic training who think their drill instructor is being unfair or mean or whatnot. Actually, I've known a lot of people who came from really chaotic alcoholic homes in particular, where it was one day it was good, one day it was bad, one day it was unexpected. It was the chaos that was the problem. It wasn't the intensity or the whole thing. So in fact, they did quite well. They loved a drill instructor who told them very clear rules, and they did the clear rules and they succeeded, right? Now, not everybody in the military follows through on that and acts in a consistent, logical way, but the folks I've worked with came from chaotic homes do quite well with it, as long as they didn't bring their own, active substance use issue with them. And then, they get into a lot of trouble because of drinking, let's say. I just met another guy with a DUI at the gate. What happened? Oh, well, I only had a few drinks. How many drinks? I had 10 drinks. What were you doing? Well, I was driving back on base. So what happened? Well, the MP stopped me. Right? Because he wasn't thinking having 10 drinks and then driving his Jeep onto base, that was any kind of problem. And then he blamed them briefly. And I said, really? He goes, no, they were right. I shouldn't have done it. Right. Okay. In the CPT work, they talk about 5 themes that represent important negative core beliefs or schemas that can be CPT confirmed by traumatic event or change. The 5 themes include safety, trust, power/control, so sort of a continuum, esteem, and intimacy. So here's an example of how you might say this to the client. Well, Captain so-and-so, Lieutenant so-and-so, whoever I'm working with, for the next 5 sessions, we're going to begin considering specific themes that may be areas or beliefs in your life that were affected by your trauma. At each session, so not you are trauma, but you have an externalized trauma that has affected you. At each session, I'll be asking you to consider what your beliefs were prior to the event, and then how the trauma has affected them and been affected by these prior beliefs. If we decide together that any of these themes bring up stuck points for you, and remember, we've already explained stuck points to them, so that's why we can say this now. I'll be asking you to complete worksheets on them in order for you to begin changing what you're saying. So what do you mean worksheet? And then we refer to the manual in this sense. We say, well, remember the earlier worksheets. The 5 general themes, as we're still saying this directly, are safety, trust, power, control, esteem, and intimacy. Each of these themes can be considered from 2 directions: how you view yourself and how you view others. And we would then say to them, here's the session flow with themes. So session 1 would be, what's PTSD? What is CPT? Sessions 2 and 3, we're going to look for the stuck points. And we are going to have a narrative piece. We are going to ask them questions. They're going to tell us their story, but it's more structured in this way. Sessions 4 and 5 could be processing the index event that we talked about earlier. 6 and 7, and this is on a 12-session model. 6 and 7, learn to self-challenge. 8 to 10, so 8, 9, and 10, trauma themes. We then look into the safety, the trust, the power control. So if you notice, we waited until later after we've gotten their feet solidly on the ground with what is CPT, who are they, what's their stuck points, what's an index of it. And now I'm getting rid of self-challenge. And then we get into the themes of safety, trust, and power control. And then sessions 11 and 12, and then if there's aftercare, which there may be, esteem, intimacy, and facing the future. So this is a pretty standard flow of the way this would run. So you can't ever talk about a concept and say, oh, everything's perfect. So some people don't love everything about CPT, some concerns. Some providers reported concerns that direct discussions of trauma could undermine the therapeutic alliance. And the providers and patients alike may believe symptom exacerbation is a barrier to treatment or common research for dropout. But the actual research shows it's actually a normal and transient part of CPT. So just like with most people dealing with the trauma in any kind of therapy or other issues too, if you remember the bimodal outpatient treatment curve, right? It's sessions 1 to 3 and 8 and more. So a lot of people come to 1, 2, or 3 sessions and then they disappear from therapy, or they come 8 or more and they stick around. You don't get a lot of 4, 5, 6s, and 7s. Why? All things being equal, by the way. Take out money, take out transportation, whatever. Well, it ends up, a lot of people start flooding, get overwhelmed, and they're like, I'm out of here. I'm going to be defensive and protect myself and leave. But people who stick around enough, they really stick around. We get a lot of good work done. Other concerns about CPT could include that certain veterans may be less ready for use of CPT, and this, of course, makes sense. Presence of psychiatric comorbidities, cognitive limitations, low levels of patient motivation, and also comorbid diagnoses, substance abuse, pain, recent hospitalization. Well, of course, but those would be barriers or anything. So I'm not defending. Yes, those are all true. They also thought ensuring quality training for clinicians and student patient readiness groups can help with these concerns. So they said, okay, let's make sure people know this better. Let's make sure. So later when I pointed out, anybody who wants to really dive deep in this, the DoD has a website. It's paid for with tax dollars. It's wonderful. We can all sign up for it, whether you're military or not, doesn't matter. It takes a bunch of hours, 8 to 20, depending on your speed. There's videos you watch. There's practice you watch. As a clinician, it's all designed for the clinician by the CPT people. They did just a wonderful thing. And it's it straight DoD or it's VA? I have it somewhere, but it's a wonderful program. It takes a lot of time, but I think it's a total payoff. It's worth it. Patient readiness groups are designed to, and this should sound familiar for anybody who's done eating disorder work with like Fairburn and whatnot. Well, of course, the more support, the more structure, you can make a greater efficacy. So patient readiness groups for CPT were designed to provide patients with skills, help support patient motivation, foster motivation to engage in treatment. And they do the same screening, training, support structures. And they also work in, as I said, at a border, they work with other psych issues too, eating disorders, substance use disorders. These are very common ways to take people who are a little fragile, a little less educated, they need more support. So we do pre-learning, pre-training, right? At the patient level, readiness to address the symptoms, initiate treatment, all these different things, absolutely, it's important. There are groups with increased likelihood of treatment. Somebody with military sexual trauma, being married, having fewer psychiatric comorbidities, no recent hospitalizations, patient belief and satisfaction with treatment, positivity. So this is from the research and what increases the likelihood of treatment initiation, what adds the odds they're going to stick around. Groups with decreased likelihood, and this was based on the studies of those military groups they looked at with VA data, service-connected disability for PTSD, being Hispanic or Latino, identifying as male, older age, and this is, again, not that anybody who was Latina would have this issue. It's the military folks in this study. And it probably meant there wasn't the right support to connect with them. It's not that somebody who's Latina can't connect with us. It's they weren't getting the support they needed. Older age, living further away from the VA. Could they have access? This may have been done before we were doing as many telehealth things, but the studies that show telehealth has been great, and other things say it's disconnected, it's the relational connection. So it really depends. Concerns about therapeutic alliance, frequent medication changes. So all of these things, of course, make sense, right? Systemic factors, well, there needs to be proper training of the clinicians. You can't have a clinician who sort of knows CPT, sort of trying to do it. It won't work as well. But that would be with anything. Available resources. You could have terrific clinicians knowing CPT, but there's way too many people on the waiting list, way too many people because they're understaffed. Many of us are in systems or have been in systems. They're just not, oh, where's Carol? Oh, Carol's doing Ellen's job. Why? Where's Ellen? Well, Ellen's out. You got one person doing 3 people's jobs, and that's not rocket science. We've all been there. And especially these days post-COVID, a lot of senior clinicians have retired earlier than they would have planned to, and now our younger clinicians are picking up the slack, or they're not. So yes, of course, we need the proper training. We need the available resources. We need the right support. who's ever in charge has to buy into this and support it. And I don't just mean financially, I mean emotionally, statement-wise. They have to make it clear, whoever's at the top or in the system has, whether it's a school, whether it's military branch, I don't care what it is, somebody in administration or leadership has to say, yes, we believe in this and you should do this and this can help you. Response timeliness, and that again is connected. Compatibility for patient. It's a great intervention. It doesn't work for everybody, right? Veteran samples saw slightly more symptom reduction than military personnel. And that was, so people who were out of the service already versus not. Well, and that could be stigma related to receiving mental health treatment. So people who were still active duty didn't want to tell people they were seeing a psychologist, right? That made them weak. Somebody who was a veteran who was already out, who knew they were dealing with issues, wanted to see the psychologist more. So that's more stigma than whatnot. And it makes sense given the culture, right? Military culture strongly influences values of strength and courage, which could impact their willingness to receive. So that, of course, is about self-care. And we would say, I think I said in a minute, but if you're willing to protect everybody around you with your life, why would you not be willing to protect yourself as well, right? We know that CPT has potential to help our military clients. They have many reasons to not want to talk to us, but when they do, they can make great change. We know their military training and culture, strength and courage, mentioned above, for instance, make them hesitant to engage with us, but when they do, can help. So here's the thing that I've said to people and other folks have said. If you can be so strong and courageous for everyone else in the battlefield, can you do the same for yourself in this therapy office? You're actually challenging them in a way to say, I know you're brave and strong and courageous out there. Right now, can you be just as strong and courageous for you in here? So your husband, your wife, your children can have you for many years to come, right? By the way, I'm not touching on suicide and other risks because I didn't have time today, but of course, we want these folks to be as stable and supported as possible. All right. That was, of course, a ridiculous amount of information in a short period of time, but I hope I've made the case why this is something you should want to learn more about. Now, let me point out the two references I mentioned before. So all three of these references are fine. They're great. This is where the research was coming from. 2023, 2023, 2023. These are all very hot off the presses type things. So I was trying to go as realistically as possible. And I was thinking, well, I love CPT and a lot of people do. Maybe it's not holding up, but a lot of research says it does hold up. Okay, but on the second slide. So, and the Rains and Resnick ones are great too. So this Resnick, Monson and Chard reference 2017. This is the book I mentioned from 2017. It's the second reference here. Great book. I could not show you their stuff. It is copyrighted materials, whatnot. The next one is the manual I said that anybody here could very easily download. So when you're done here today, if you want, just Google either Resnick, Monson, and Chard, or just Cognitive Processing Therapy, Veterans Military Version. It is on the Department of Veterans Affairs website. You'll get the manual. It's downloaded. It's from 2014. Everybody, it is freely, it's paid by military dollars, which is tax dollars. Everybody's welcome to it. But it specifically says for the clinician to use with the patients. So I'm a presenter using it. That is why I am not distributing it. But all you have to do is type that into Google if everybody gets it. There was the one in red. You should 100% get that. It'll get to the manual. It's very, very useful.